Awesome. Hi, everybody. We are going to give everyone a couple of minutes just to get logged on. And while everyone is getting logged on, we will go ahead and take care of some housekeeping items. So to kick things off, I'll introduce myself. My name is Brooke McGivern. I'm a speech language pathologist and the Director of Marketing and Communications here at Tim's Medical. I am super excited and honored to have Laurie Wennerholm and Aaron Padilla with us this evening to present Finding Our Way with Fees. Their expertise is absolutely invaluable, so I can't wait to learn from them tonight with you all. A couple of items to go through before we jump into our content. This course is eligible for 0.1 ASHA CEUs or 1 PDH. If you are interested in obtaining ASHA CEUs, we ask that you stay for the entirety of this presentation and that you fill out a brief survey at the end of the course. I will post the survey in the chat, so feel free to fill that out at the end of the course. And if you miss it, if you're on iPhone, no worries, it will be sent out via email as well. If you're interested in obtaining a personalized certificate of completion, send us an email at tims-univ@tims.com and we will get that over to you. And this will all be put into the chat. If you have questions that come up during the course, feel free to put them in the Q&A box or the chat as well. And Laurie and Aaron will address those questions at the end of the course. And with that, I'm going to go ahead and hand over the floor to Laurie.
Thank you so much for having us. I'm just going to try to share my screen. Okay. Okay, wonderful. Well, thank you so much for being here with Aaron and myself. We're going to talk to you about finding our way with fees. Perhaps we have found our way. Maybe we are still looking. But if you take a look here at this first slide, you can see some very famous larynges. They're of your speakers, but I'm not going to tell you whose is whose. I can tell you mine's the old analog. I'll just tell you. I'm the one on the right. Anyway, we're really happy to be here, and we really would like to first thank Tim's Medical and Brooke McGivern for giving us this opportunity to speak with you and share what we have learned over the years, and for sponsoring this learning event. And it's just a wonderful company and wonderful. So thank you. So here are our disclosures. And any thoughts, views, and opinions are our own, but we're using the current evidence as a guiding principle and above our current disclosures. Thank you. And here's our agenda. So we're going to go through a little historical background of fees. I like to take it way back. We're going to talk a little bit about sterile processing, storage images, integration of fees, some competency processes, and specific things like infection control, scope types, anesthetics, fee scales. And then we're going to talk a little bit about some peaks and pits with fees. And then, of course, the Q&A. I think someone might have a question. But hopefully not for me yet. So here are our learning objectives. You can just take a look at those. I won't belabor them, but really to sort of understand this tool, its history, to understand some components of a fees exam, and competency processes, and to really sort of look at some fees and integrate some scales. So if I bring it way back to the landmark paper by Dr. Susan Langmore back in 1988, that was called Fiber Optic Endoscopic Examination of Swallowing Safety, a New Procedure. So here comes fees on the scene. And here we can see on the right, Dr. Langmore with her fiberscope and her setup. And really, she described this in 1988, which was the first reported fees exam, which had an extra S on it for safety, because they were really looking primarily at safety at the time. And we knew that that's a little bit different from the way that we view fees now, and was really used to determine safety of oral feeding for patients who really could not participate in a fluoro, right? So those with facing immediate discharge, or those with contractures, or patients on ventilators, on ICU, nursing home patients. And the question that was asked, or the exclamation was, can my patient swallow with safety? And so this is really sort of the nuts and bolts of it. And she described this procedure developed in 1986 at the Ann Arbor VA in Michigan. She published this paper with greater than 50 subjects. So she looked, so they were doing this procedure with many subjects. It was deemed safe. It was effective at allowing them to understand patients' swallow function from a safety standpoint. And interestingly, there were only 7 references in the reference list. And if we fast forward to 2017, when she wrote a paper called The History of Fees, there were over 100 references in that list. So where we've come in 30 years is just amazing with fees. And so she, Susan Langmore and her head and neck colleagues developed this tool. And that initial laryngoscope had a very rudimentary eyepiece and fiber optic rods. It was a very large, had a very large insertion tube, and it was connected to a light source. So these are like the, sort of very, very old types of equipment. There was no lidocaine mentioned with regards to anesthetic. And she did, not surprisingly, in an endoscopy that goes transnasally, she was looking at similar things, appearances of structures, and then some of those pre-swallow tasks that we all still do today. And food trials, they were only colored green, and they were calibrated amounts. So when people used to argue that fees did not have a protocol, it actually did, and she published that in her first book. And so everything was dyed green. There were no other colors used except blue. And the reason she did that was because it would be able to be seen against the structures of the pharynx and larynx. Interestingly, the study was terminated after an episode of silent aspiration, which we know differs from today's fees. And the sensitivity testing was light touching of the tip of the endoscope to the epiglottis or other critical structures. So she did mention a sensory component. And you could do a modified fees for patients that were high risk using a 1 ml bolus of water that was green dyed that could look at your tolerance of your secretions. And in this particular case, aspiration, not necessarily residue. However, they did not describe any processes for recording. So this was all done just by your recall. Then Dr. Bastian published in 1990 a paper that he described this process, this test called the video endoscopic evaluation of patients with dysphagia, or the VEED. And he talked about it being completed by him from early as 1984. So he was trying to sort of establish that assessment of swallowing via endoscopy was done prior to speech pathology by physicians. And here's his setup. And he did have a nice VHS, if anybody knows what that is, an old recording device. Let me get my stuff out of the way. This was used with post-surgical head and neck patients. It also used a fibroscope, an EMF Olympus. He did have slow-mo and recording capabilities. He mentioned the necessity of suction in case patients got into airway trouble. He mentioned a nasal anesthetic. And he started sort of opposite the way speech pathologists would, with pudding and crackers and then water only if appropriate. And he used methylene blue, which is no longer used today because of some challenges with the health of patients that that ingested methylene blue, but that's for another talk. And he did some pre-swallow assessment as well. He did a countdown swallow, so we know that that can be problematic. From Bonnie Martin Harris's literature. And he was the first really to describe pharyngeal image biofeedback. So could you use this as a tool to teach patients how to swallow better? He did talk about strengths and limitations, but he didn't mention that this exam could be completed by a speech pathologist without the sort of company of a physician. This was really nice. It was one of the first, or maybe the first, graph that looked at, or table that looks at a comparison between this video endoscopic examination of dysphagia and fluoro. And so it looks at pharynx mobility closure all the way through oral cavity. And it talks about what VEED would be excellent and what MBS would be excellent, but also not. And then clinical utility, as you can see, he has a little bit of a bias towards his exam versus modified barium swallow. And so this was really nice. And we still use some of these concepts today when we're teaching, the comparison of fluoro versus fees. Then Jonathan Aviv came on the scene in the 1990s, and he's a head and neck surgeon, laryngology trained, and he sort of took the technique to a higher level, and he created this sensory testing procedure. And as you can see in this image, this is the endoscope, and it has two channels, one for light and one for an air puff. And essentially, you'd have to get specialized equipment to do this FEES with sensory testing, which is the ST. And once you sort of presented this puff of air to the arytenoids or the aryepiglottic folds, if the patient didn't tightly close the larynx, called an LAR, that would mean they had sensory, right, superior-laryngeal nerve issues, and those patients would be deemed unsafe to swallow. And many of these patients were made NPO without really looking at motor function. He actually still, when I looked, he still has this protocol on his website, but the equipment is no longer commercially available. And so, sensory testing perhaps, was a really nice thing and a nice adjuvant, but potentially it made us really much more conservative about patients because we never even looked at their motor function if they failed to elicit this LAR. So who passes the scope, right? In 2021, Asha said it was in the speech pathologist scope of practice. Thank you, Asha. And then in 2014, in England, speech language therapists got competency awarded to them. But we really need to understand that in some centers in the United States and Canada, that otolaryngologists remain the only professional allowed to do this. So we consider ourselves fairly lucky that we're able to do this, and we absolutely should be with the right competency training. So getting back to our turf challenges. So just like when a new assessment or something new comes on the scene, there are some turf challenges. And so the first turf challenges that I learned about were between Jerry Logeman and Susan Langmore, and they were like wonderfully lovable colleagues. But Jerry and Susan were sort of arguing for, whose test is more valid, more reliable. Jerry really thought that there were significant limitations. If anybody doesn't know Jerry Logeman, she was the grandmother of swallowing and really created the modified barium swallow in its infancy back in the late 70s. And so she really thought that FEES was an inferior type of test. And so there was some turf wars there. And then you had the physician turf wars that, they really thought speech language pathologists might not be the right types of professionals to be passing an endoscope, right? And then I just need to note that Jonathan Aviv did really empower speech pathologists. He used to have a training program at Columbia Presbyterian. If any of you know Dr. Eric Blicker, he was trained by Dr. Aviv. And so Jonathan Aviv actually was really a proponent of training speech pathologists to do this in conjunction with, physicians, but independently as well. So which is better, FEES or fluoro? Are they created equally? And I think this is the million-dollar question. Right? And so based upon a compilation of data points, you can see that with the variables being sensitivity to aspiration, specificity to aspiration, sensitivity to residue, right? The FEES and fluoro rank pretty high, right? And if we think about what is sensitivity, that means a test is good at detecting a disorder without many false positives, right? So it's sensitive to detect the positive aspiration event. So FEES is pretty high, which is about 90%, right? And then you have very high for FEES, so it's good, right? And specificity, meaning the test is good at correctly identifying those without that parameter, right? So not too many false positives. And so they both rank pretty well. So how do we get trained as speech pathologists to perform FEES? Susan Hiss and Dr. Postma back in the early 2000s published a paper that really sort of summarized what Asha said, and these standards sort of hold true in current state. And there are no exact number of hours endorsed by Asha with regards to, what constitutes competent. And back in 2002, the knowledge and skills for SLPs performing FEES was created. And really, it specified that competency in general dysphagia was critical as a precursor to anything. So you couldn't just work with patients with aphasia and not dysphagia and then want to perform this. You had to have, general understanding of dysphagia, cranial nerve function, normal swallow, pathologic swallow. And then it specified that between 10 and 14 hours of formal classroom instruction with teaching you endoscopy skills, interpretation, and the utility of fees and different disorders and what they look like under endoscopy. And then performing or sitting for 10 to 20 observations of fees on patients with dysphagia, and that's important. And then lastly, independently passing an endoscope, and this is critical for the purpose of fees, not just to pass it, say I got in without hitting tissue and coming out 25 to 50 times under direct supervision of somebody who is competent to pass the scope. Could be GI, could be otolaryngology, could be another speech pathologist. And so this last point is really critical because I work with Dr. Blicker, and we help train individuals to perform fees independently. And many times the mentees will say, okay, I'm going to, pass the scope. They go in and they're like, okay, I'm coming out. And I'm like, okay, but that was just passing without sort of harming anybody, right? Really, this is a swallowing assessment. So we really need to pass that scope with the end result being you're watching patients swallowing and making observations about function, safety, and efficiency. So that's really an important point. And when you're going for training, I want you to think about that. State variations. So just so you know, different states have different variations in what they consider to be within our scope of practice. In New York, it is within our scope of practice and has been. New Jersey had a little bit of a tumultuous past, but after advocacy efforts, speech pathologists are competent, and here are some specific parameters for that competency. In Illinois, rigid endoscopy and flexible endoscopy. So basically this slide just shows you that if you're working in a different state or if you're going to move to a state that you are unsure of what the variations are, there are available within the Office of Professions for each state. So back in the early 2000s, those standards were created. So ASHA more recently published a fees practice tutorial, which is an updated paper that talks about indications for fees, procedures, interpretation, documentation, and training requirements. Subsequent to that, a fees rating scale paper was put out because all of these rating scales and validated measures were coming on the scene. And how do we use those and why are they important? We're going to talk about some of those today with Aaron. And then a pediatric fees implementation paper was also put out. And so these are just important sort of updated literature for people to refer to. And here are some of those links for you. So when we think about scopes themselves, there are many specifications that if we're starting a program, we really need to think about, right? We need to think about, are we getting a fibroscope, which is a fiber optic scope has optical bundles that can break and change our optics. Video scopes, which are mostly what people are using these days, that have a video at the distal end and do not have these bundles of optic fibers that were used many years ago. Are they reusable and do they need to be sterilized or high-level disinfected? And what is the number in your arsenal, right? So if you only have one scope and your scope breaks, what is your backup plan, right? And so that's a really important consideration, especially if you have a large population of people using the scopes. What is your insertion tube diameter? Oops, sorry about that. Is it a small insertion tube diameter, like a 2.6, which you would use if you were considering pediatric fees? There are multiple brands, and you probably have gone to DRS or gone to ASHA and seen a lot of these vendors, right? And so what system would work well for you? How are you going to integrate that system into your Epic medical record or whatever you're using? How are you going to store those images? How are these scopes going to get delivered, picked up, and tracked? Those are also very important things. How are you going to process them? Are they going to be sterilized, which is a gas sterilization, or disinfected using like a bath? And what might be your institutional considerations? So these are all reusable scopes. Up at the top, this is an Olympus image. Right here is a Storz Telepax system. This is the Storz disposable scope, and this is Ambu. So I don't represent any of these companies. I'm just telling you there are many scopes on the market for consideration. With regard to image quality, as you can see, the fibroscope, it gives you the worst image, right? It's the most rudimentary image, where if you see this glottic cancer, this early glottic cancer on the right vocal fold, if you were to use the fibroscope, you might not really be able to look at that and to find that. Not that you would look at that as a speech pathologist and diagnose it, but you'd be able to say there's something white and patchy on that vocal fold with this HD video scope. So years ago, when I first started, we used these fibroscopes, and you can see sort of this pocking of the image, which really means those fibers are breaking. Those fibers are broken in those locations, so you can't get an image. And over time, that would, sort of take over the entire image. And so that would be a challenge, and your scope would be deemed unusable. And so that's just a challenge there. And so I thought this was interesting because when I walked into my son's follow-up with the orthopedic surgeon, there was an endoscopy image up. And so this, I'm not going to test anybody, but this is a labrum repair. So as you can see, this is actually a video endoscope. And so we use endoscopy everywhere. I just can't seem to get away from it, and it's such a useful tool. So when we consider things as we're developing our programs, right? These, I was tasked with developing a fees and endoscopy program at a hospital where I worked, and there were multiple lessons learned, right? And so here's one that, sometimes you go to pick up your scope and it says do not use, and you might not have another one to use, and you have a patient waiting for you for a fees, and so that can be challenging. And who do you borrow from, right? Other things are if you use scopes that have multiple little attachments, right? So some of these were for camera heads and for light sources, and each of these component parts needs to be sterilized or disinfected based upon its own instructions for use. So you can't just throw the whole scope in with all these little pieces. And if you can imagine in a big sterilization department, how frequently these get lost. And these are hundreds of dollars. So just certain things to consider. So this was interesting for me. This is more fun that I had. So I went to do a fees. I opened up the box that was holding my fees. I take it out and I look at it and I said, wow, there must have been a Rottweiler chewing scopes down in central sterilization. And so this was a scope that was gas cleaned without a gas cap. And so essentially the gas was sort of shunted through the rubber of the scope, and it blew up like a balloon, and then it exploded. And so these are also some challenges that I had with the distal tips of the scopes, just because of challenges with sterilization and processing. And so these are just things that you need to think about and make sure that are discussed when you're creating a fees program. So now I am going to turn this over to Aaron. So I'm going to stop sharing my screen.
All right, thank you, Laurie. Let's see here. Here we go. Okay, everyone can see things. So thank you, Laurie, for that introduction and kickoff into our session this evening. And like Laurie said, big thank you to Brooke and the entire team, Tim's team, for the opportunity to present. So Laurie showed some photos of what can happen to scopes during sterile processing. So let's talk about that a bit more. Muscarella and colleagues discussed sterilization and high-level disinfectant for laryngoscopes. Cleaning differs pending the type of instrument. Critical instruments are those that penetrate sterile tissue or contact bone, blood, or any vascular, such as cardiac catheters or biopsy forceps, and need to be sterilely processed. Whereas semi-critical instruments would be those that contact mucous membranes and have a lower risk of nosocomial infection. This risk is further reduced if there is not a therapeutic working channel. These instruments can be cleaned using high-level disinfectant. So think of your fees scope. Scope that has a therapeutic working channel may be a bronchoscope where they're lavaging the lungs or taking biopsies, or a gastroscope. High-level disinfectant is used for semi-critical instruments and destroys a multitude of bacterial endopores, but not all. Solvents that are used can include hydrogen peroxide, peritectic acid, and glutathione. For critical instruments, hydrogen peroxide plasma, ethylene oxide gas, so Laurie shared a story about that, and pressurized steam are things that can be used. So some things to think about as you're developing your fees program is what are the specifics for your specific scope? So maybe reaching out to the vendor and manufacturer, and then what's specific to your institution. Here's a sample cleaning protocol as outlined by Muscarella's publication. After the exam is completed, pre-cleaning occurs using an enzymatic sponge or cleaning with a detergent that is compatible with your scope. A leak test is then completed to ensure that there is not a hole in the scope where bacteria-laden contents can harbor. If and when the scope passes the leak test, cleaning is completed to remove any debris and reduce microorganisms. The scope is then soaked in a detergent and cleaned with a soft sponge or brush or bristle. High-level disinfectant is up next to destroy additional microorganisms. The scope is then immersed and rinsed. If your facility completes sterile processing of laryngoscopes, this would be the next step. So let's talk about data. This is one of my favorite parts of the discussion. So why and when and how should data drive our decisions? When completing diagnostics, we really want to implement the evidence into clinical care, and we really want to consider the role of fidelity. So if Laurie does a FEES in New York and I do a FEES here in the Southwest, we want to have comparable exams. That way, we have similar outcomes. Patients aren't going through multiple tests. But the tools that we are using, how do we know that these tools are valid? Do they measure what they're intended to measure? As we continue our discussion this evening, we'll talk about anesthetic, colorants, rating scales, in addition to normative data. So let's continue to find our way. First up is anesthetic. So early work by Leader and colleagues investigated the impact of topical anesthesia and vasoconstrictors on comfort for laryngoscopy and FEES. So real important point there is two separate things, laryngoscopy and FEES, and how Laurie mentioned earlier, it's a difference of just, a quick pass for a laryngoscopy versus an actual swallow evaluation. There were 152 participants with an age range of 18 to 84 that were randomly assigned to one of three groups. Group 1, the anesthetic group, Group 2, the vasoconstrictor group, or Group 3, the placebo group, with 54, 50, and 48 patients in each respective group. Comfort ratings for utilization for vasoconstrictors and placebo was slightly more than mild discomfort, with the topical anesthesia group reporting slightly less than mild discomfort. A one-way analysis of variance for independent measures among variables found that these findings were not significant. But some things to consider is the volume of anesthetic was not reported in the publication, and patients were not assessed under each condition. So patients were only in one group in this study. Although this is a bit different, this publication by Hernandez and colleagues looked at the role of anesthetic in high-resolution pharyngeal manometry. So earlier in our discussion, Laurie shared some diameters of scopes that are used for FEES, and it can be as small as 2.6 or as large as upper 3. A manometry catheter, you're looking at maybe about 4 millimeters. So Hernandez and colleagues investigated patient comfort levels with and without atomized lidocaine who had high-resolution pharyngeal manometry. There were 29 participants, which participants served as their own control, completing 2 separate manometry exams, 5 to 7 days apart. A visual analog scale was used to rate comfort with manometry in addition to pharyngeal pressure measurements with locations at the velopharynx, tongue base, and upper esophageal sphincter. So there's the age-old question of, does anesthetic impact swallow function? So this study helped to answer this. Participants either had 2 cotton swabs dipped in 2% viscous lidocaine solution or 0.4 ml of 4% lidocaine in addition to the 2% viscous lidocaine cotton swabs to each nair. There were no significant differences in pharyngeal pressure as listed at the velopharynx, tongue base, and upper esophageal sphincter. 28 of the 29 participants reported they preferred the atomized lidocaine and differences in perceived comfort as measured with the visual analog scale. The authors report the viscous anesthetic to the nares does not reduce discomfort in the same way that the atomized lidocaine does to the nasopharynx, but something to consider with the cotton swab lidocaine is it really all depends on placement, and other points of consideration is a manometry catheter is going to be generally a lot larger than a laryngoscope that we're using for FEES. Finally, Odia and colleagues investigated 17 patients with dysphagia under 2 conditions, a non-anesthetized using a decongestant only versus an anesthetized condition using decongestant and 0.2 ml of 4% atomized lidocaine. They investigated the impact of the anesthetic on penetration aspiration scale scores, residue, and comfort. There was no significant difference in PAS or residue, but there was a significant difference in comfort with the anesthetized group, reporting having less discomfort during the exam. On the topic of anesthetic, our colleague Dr. Meredith Baker-Rush had a recent publication investigating speech pathology training and use of topical anesthesia, as well as discussing confidence and knowledge around the FEES exam. 83% of participants reported high levels of confidence in their knowledge of FEES, yet 31% reported high levels of confidence in skills to perform the FEES. So I think one thing that we can take away with this presentation today is the role of collaboration. Laurie and I are on completely opposite ends of the country, but coming together for a similar goal of how can we serve patients, improve outcomes, and really develop the best possible care that we can provide. So connect with all of those colleagues that you meet at all of these wonderful meetings that we have. So next we'll be discussing the various roles of scales and their inclusion in your FEES exam. So many thanks to Laurie's colleague, Jackie Mojica, for the slides and inspiration of slides and images to follow. We'll be discussing measures of swallow safety, swallow efficiency, overall swallow severity, measures of laryngopharyngeal edema, such as the revised Patterson scale, epiglottic retroflexion, that's right, that can be observed on FEES, in relation to pharyngeal squeeze, forceful breath hold for supraglottic closure, as well as secretion scales. So speaking of pharyngeal squeeze, Fuller and colleagues completed simultaneous fluoroscopy and FEES and found 93% agreement between diminished pharyngeal squeeze during the speech task for a strained EEC and statistically significant reduced pharyngeal constriction on video fluoroscopy with statistically significant findings. And note that all other speech tasks have limited support in the evidence. We'll spare my example of the strained EEC for the presentation today. We'll let everyone practice that on your own. Here you can see in the images, we have bilateral, let me see. So on the left, you can see bilateral pharyngeal engagement during strained EEC. In the middle, you can see unilateral weakness for a head and neck cancer patient. And lastly, bilateral reduced pharyngeal contraction. Although we cannot visualize many physiologic components of swallowing during FEES, we can observe epiglottic retroflexion, is depicted in the image on the far right. There is some degree of inferencing here, however. If after whiteout you visualize the epiglottis returning to its upright position, one can suspect that there was some degree of inversion, and this can be helpful where frame-by-frame analysis is completed. And also just really knowing your type of equipment. If you have a scope that Laurie discussed various types of scope, if you have a scope that has an automatic light source, you may want to turn it to a manual setting, and that may be easier to observe epiglottic retroflexion. Moving on to secretion scales, the Murray
Aaron, can I just stop you for 1 sec? Would you
Yeah,
mind
please.
just adjusting your screen because the far right of your slides can't be seen. So I'm just
Oh.
wondering if you might be able to. I thought it was just
Okay.
me. There you go. Good. All right.
Thank you.
Awesome.
Thank you for that catch.
Yes, yes. Thanks, Brooke. I thought it was just me, but
Sorry about that, everyone. The Murray Secretion Rating Scale is a 3-point ordinal scale originally investigated on 47 hospitalized patients with swallowing disorders. In the original publication of the 18 to 47 patients that had a Murray Secretion Scale of 2 or higher, all aspirated on FEES. As depicted here, we have a grade of 0 where no visible secretions or only transient secretions in the vallecula and piriform sinuses. A 1, or the middle image, is where secretions are visible in the laryngeal vestibule or surrounding structures bilaterally or are deeply pooled. A 3 on the far right is where secretions present in the laryngeal vestibule, and although not in our image, a score of 2 equals secretions that change from a 1 rating to a 3 rating during the observation period. Continuing with our discussion of secretion scales, the Marion-Joy is a 5-point Likert scale. The original publication included individuals aged 10 to 25, including a mix of hospitalized and non-hospitalized individuals, as well as some patients with a trach. Patients with a higher score had a higher likelihood of laryngeal penetration and aspiration. 86% of patients with a profound score of 5 on the Marion-Joy secretion scale were observed to aspirate food or liquid on FEES as compared to only 21% of patients with a Marion-Joy secretion severity scale of 1. The mean secretion level for patients who aspirate was 3.71 as compared to patients who don't aspirate was 2. The New Zealand Secretion Severity Scale was originally investigated on 180 patients across neurologic disease, critical care, structural anomalies, as well as patients classified as other. The endoscopist reports on the amount, location, and response to secretions. Although a weak Pearson correlation coefficient, the level was significant between the New Zealand Secretion Scale and PAS scores. As you can see here from the various definitions used in the tool, the original publication is linked in the handout that we have on the last slide. So something to consider when you're doing an exam is if you have a secretion severity score rating that is a higher likelihood of aspiration, and you maybe have a patient that is a high risk host, and we'll talk about host considerations at the end of the presentation today, maybe, that helps in your clinical decision making of after you've tried various compensatory strategies, when do you stop your exam? As we talked about earlier, stopping after the first bit of aspiration is no longer the standard with fees, but how can we determine when to discontinue an exam? So moving beyond secretion rating scales, we will next discuss additional scales for measure of swallow safety, efficiency, and total severity. We'll discuss some of these very briefly and others in more detail. Briefly, the pooling score assesses residue in the following locations: the vallecula, what the authors describe as the marginal zone, the laryngeal vestibule, and the vocal folds, in addition to lower vocal fold residue. The BRACS reports residue on the pharyngeal wall, base of tongue, vallecula, epiglottic tip, lateral channel, piriform sinus, postcricoid space, arytenoids, interarytenoid residue, laryngeal surface of the epiglottis, laryngeal surface of the area epiglottic folds, the anterior commissure, vocal fold residue, and posterior commissure residue. The MFRRS includes residue ratings for the vallecula and piriform sinus residue. So that might be some things to consider with your various institution and group when you're selecting a scale. Now we'll get into the scales that we're talking about in more detail. FACES was created by Dr. Curtis and colleagues using a 100-point visual analog scale to estimate the amount of residue listed in the predetermined anatomical structures. There's a ton of photos in the original publication linked in the handout, as well as in Dr. Curtis's website. Check out the TIMS archives for Dr. Curtis's presentation on FACES from last year. FACES measures residue at the oropharynx, hypopharynx, epiglottis, laryngeal vestibule, vocal folds, and the subglottis, or put another way, looking at the amount of aspiration. The original publication reports excellent intra-rater reliability for identification of residue at the epiglottis and within the laryngeal vestibule, with good intra-rater reliability for residue at the locations mentioned above. There's a moderate level of inter-rater reliability, or excuse me, it was inter-rater reliability initially, now it's intra-rater reliability at the predetermined locations, and excellent inter-rater reliability for measures of the hypopharynx, epiglottis, laryngeal vestibule residue, with good inter-rater reliability for the vocal folds, oropharynx, and subglottic residue. So when selecting a tool, I think something to think about too is looking at the reliability measures. So if I do a FEES today and I score this FEES today and I'm looking at intra-rater reliability, that's looking at if I score the same FEES tomorrow, am I getting the same scores? When I'm looking at intra-rater reliability, if I do a FEES and if Laurie does a FEES, are we getting the same scores? Because if I'm seeing the patient today and I score today and Laurie picks up care tomorrow, we want to make sure that we're reliable within our own service and team and so forth, so that those measures of the psychometrics from the publications listed in the handout can help you in determining what scale to select for your respective service.
Aaron,
Next.
sorry
Yes.
to interrupt again,
No,
but
please.
the slides are still cut off, and so I was going to see if you can. Yeah, there we go.
That work?
Yep, now we can see them perfectly. Thank you.
Sorry, everyone. We'll make sure to have a handout for everyone in case there's anything that folks missed. All right. Okay. The Yale pharyngeal residue rating scale is separated in a vallecula and piriform sinus rating scale, and we have images from the authors in both slides. The scales use anatomical landmarks in addition to percentages to assist with ordinal scoring. As you can see, we have trace follicular residue with the score of, or with residue between 1 and 5%. This is in image A, with trace coating of the mucosa. Mild is 5 to 25% residue where the epiglottic ligament is visible, and this is depicted in image B, and we'll just go down the line for the rest of them. Let's see, moderate residue is 25 to 50% of the vallecula filled with the epiglottic ligament covered, and finally, severe residue being greater than 50%. The intra and inter-rater reliability for the vallecula portion of the Yale is excellent, is reported in the original publication of the scale. Moving on to the piriform sinus rating scale portion of the Yale will still go through image A, B, C, and D, and E for each respective rating. Trace residue is again 1 to 5% with coating of the mucosa. Mild is 5 to 25, up to the posterior pharyngeal wall, up to a quarter full. Moderate is 25 to 50% up the posterior pharyngeal wall, with severe being greater than 50% filled to the level of the area epiglottic folds. Intra-rater reliability was excellent, and inter-rater reliability was very good statistically. So now I'm going to hand things off to Laurie to talk about the revised Patterson scale.
Good. So we'll just keep your slides up here so that we don't have to go back and forth. But during her PhD work, go Heather, she revised Joe Patterson's original edema scale. And we know that this is an important tool, especially in current state, especially in the head and neck space, where well, can we go back to the revised Patterson scale? Sorry. Oh, there we go. Okay, great. So we know that this is a really important scale in current state because, especially in the head and neck space, there is, an increased interest in lymphedema, both external and internal components. And we understand, which we didn't before, that lymphedema is a precursor to the fibrotic process. And we know that the fibrotic process in patients with head and neck cancer is what really creates a significant degree of dysfunction with swallow function, physiology, movement, closure, opening, right? And so how the structures interact with one another is impacted by the degree of edema. And edema is related to different types of treatment paradigms, right? So surgery, chemoradiotherapy, that's not for this talk, but there is an edema rating scale. And as you can see here over on the left-hand side, you can see a normal larynx with no edema, right? And as you can appreciate in the remaining slides, here's an analog scope. You can see the tongue base has some edema, right? You can see that epiglottis is sort of a little bit fatter with some fluid buildup. And so you can see the emergence of edema. And basically all the way on the right side, you can see that big thumb-like epiglottis, right? And so how's that going to function to retroflect and really cover the airway? And so this was a way that people could define the extent of edema within the laryngopharynx and within its structures that are critical for swallowing via endoscopy. And it also gave us a way of tracking things, right? And so maybe a patient presents with normal, swallow structures, 3 months post radiotherapy, and then, many months out, all of a sudden you'll see, and they're discussing their change swallow function, and you can say, well, there's a structural correlate to go with that functional problem. And so this really, and we'll talk about later why this is a peak, but at the American Board of Swallowing and Swallowing Disorders Summer Series, which I'll plug from last year, which is coming up this year, but not with the same speakers, Dr. Brodsky talked about edema and how do you measure this in other populations, right? And so we talked a little bit about how this could be something applicable. Edema is edema, doesn't matter how it got there, right? And so for your post-extubated patients, descriptors of edema can be relevant based upon these findings. So that's the revised Patterson edema scale, and kudos to Heather. So this is an example of a patient of mine who had locally advanced oropharynx cancer treated with chemoradiotherapy. She was about 3 months post treatment completion, and these are her scores, right? And so you're looking at epiglottic, you're looking at molecular, you're looking at true folds, false folds, and you can see that those lower structures that were probably out of the direct beam of radiotherapy got less potentially, right, radiation, and therefore were less edematous. And there's just a sum of severity of structures. There's no normative, right? I mean, norm, I guess, would be 0, but, for particular patients, sometimes even at tumor, at, diagnosis, they'll have some edema based upon backup from the burden of the tumor. So this is just the Patterson sort of in vivo. I think you can go to the next slide. And then the digest, right, which is another scale by Dr. Starmer based upon the structure by Dr. Hutchison that really gives a safety and an efficiency grade using familiar, right? We use the PASS all the time. So using the penetration aspiration scale score, as well as a measure of efficiency, which is the amount of residue remaining in the pharynx for different consistencies. And if you can advance the slide, that would be great. And I can give you an example of the digest fees. So Aaron, could you, yep. So you can see the puree bolus on the right. We can play that and you can see the degree of residue there. Hopefully it plays a little bit better than it's looking for me. Oh, there we go. Oh, it's slow-moing itself. I don't know why that's happening, but there you can see, okay. And you can see that degree of retention in the vallecula. Now you can see some green out there. And after swallow offset, you can see that most of that is cleared with a secondary swallow. And this is a thin liquid bolus. So we're going to talk about, and there's that secretions, right? Those standing secretions in the pharynx. You can see the edema that we can appreciate from a Patterson scale. And you can see that thin liquid bolus swallowed, and you can see nothing in the airway. I ask the patient to say E to sort of stretch the larynx out so I don't have to traverse the epiglottis and get in there. And you can play the solid for us. And so the patient swallowed once already. This is a solid bolus. You can appreciate that cookie. And it will eventually not, and it cleared, right? And you still have a little bit of that retention on the tongue base. And so you can advance. You click one more time, Aaron. I think you can pull up what the patient's digest score was. And so you can see that this patient did not have a safety impact. So this gave you a really nice functional information, but the efficiency score was significant, was severe. So that overall digest scale would be a grade 2, which is overall moderate, right? And this gives us nice information from which to compare outcomes, right? Based upon our swallowing therapeutic interventions, compare over time, right? Use as a diagnostic tool, a therapeutic tool, as well as a research tool, right? And so digest fees, I strongly, it's so easy to use. And I think it just gives us really nice information. I remember, years ago, Dr. Hutchison talked about, what does instrumentation give us? It gives us information about anatomy, physiology, and function. And so really these scales are all showing us that. Physiology less so because you can't see well physiology in a fees, but you can get certainly information on function of swallow. Okay.
Thank you for going over that with us, Laurie. So now let's talk about what is normal. There was a recent Timms University presentation by Dr. Steele and Emily Barrett where they discussed normative data from the Steele lab for various measures found in aspect C for video fluoroscopy. For fees, Dr. Kara Donahue and colleagues, as well as Dr. Curtis and colleagues, have reported data for fees in community-dwelling adults. Across the studies, there was a mean age in the Donahue study of 36, with an 11-item bolus protocol detailed in the publication. The Curtis publication, 30 of 39 patients were under the age of 60, and there was a 15 bolus protocol utilized for this publication. The majority of patients had a New Zealand secretion severity scale of 0, and across both publications, over 70% of patients had a PAS of 1 or 2, with approximately 20% of patients having a PAS of 3. They also looked at the presence of residue for community-dwelling adults, and the presence of residue in the Curtis publication was limited. Dr. Donahue and colleagues reported that 73% of their sample displayed no residue as measured by digest, with 24% of participants being mildly inefficient. Regarding safety, we can see here the presence of aspiration was rare. However, as observed by Curtis and colleagues and not by Donahue and colleagues, the amount of aspiration was small with the exception of 2 patients. For digest total scores, 73% of individuals had a digest total score of 0, with 24% having a total of 1 and 3% a total of 2, noting mild and moderate dysphagia. Of the 27% of participants that were considered abnormal, their scores were largely driven by reduced efficiency. Donahue and colleagues point out that digest residue after this first swallow versus VASIS rating residue after all swallows are completed. So I think an important part of both of these publications is when we're looking at the whole patient, when we're seeing residue on fees, or you're seeing various PAS scores on fees, where do these compare comparatively to normative data? The samples were of younger patients essentially, but I think this is a start and it's going in a good direction. We can't talk about fees without talking about whiteout. So whiteout occurs during pharyngeal constriction. For video fluoroscopy, we know that recording and storing at 30 frames per second is optimal. For fees, if we're completing and storing at 30 frames per second, whiteout should be anywhere from 12 to 24 frames or 0.4 to 0.8 seconds, as reported by Manzika and colleagues. So now we're going to kind of speed through some things because we want to leave times for questions, and we have some peaks and pits that we want to go through. But there are some data on colorants. Marvin and colleagues completed a publication looking at green dyed liquids as compared to naturally non-dyed milk. They investigated swallow safety for 5, 10 ml thin, mildly thick liquids and a 90 ml water swallow challenge. They observed deeper airway invasion with increased frequency with green dyed liquids as compared to white milk. Taking things a step further, Curtis and colleagues investigated the effects of color, coating, and opacity. They found that pharyngeal residue was detected more frequently for liquids that were blue, would coat, or were opaque compared to liquids that were white that did not have a coating effect or were translucent. So they used barium versus white milk, white water versus white milk, white water versus barium. Penetration aspiration was detected more frequently for liquids that had a coating effect. So this was the white water that had the white dye in it. Coating effect was, the authors concluded that coating effect was the most important variable for identifying residue and airway entry, and that was the white dyed water as compared to barium. I think something to consider is if you're implementing this into your respective institution, following the protocol that the authors use for mixing the various colorants and contrasts. For this publication, they used 5 ml of white food colorant diluted into 90 ml of water. And there's a lot of up-to-date stuff on Dr. Curtis's website and some sample protocols for that as well. As we conclude our discussion today, before we get into our peaks and our pits, we can't finish our discussion without the missing piece of the puzzle. So we've talked a lot about anatomy, physiology, swallow safety, efficiency, edema, and secretions. However, we have to note that that's only one piece of the puzzle. There is a missing piece that we did not discuss today. That piece is looking at the whole patient, and a further piece is taking into account the patient family wishes and values when providing holistic patient care. Such a tool is the bolus framework, where the clinician looks at the contents of aspirate, oral care, lifestyle, and measures of mobility, unintended or iatrogenic disease, and overall system status or chronic conditions that increase the odds of adverse events. But fees can also help us in our planning for instrumental assessment of maybe you have someone on ECMO, on high flow nasal cannula, and it could be potentially iatrogenic to take them down to fluoro and travel out of the ICU. Maybe fees will help us to answer the clinical question in that situation. Or maybe the frequency of aspiration is really important, and we have a patient with a progressive neuromuscular disease that has a higher likelihood of aspirating secretions. We can visualize that on fees. So that will help us to answer all of our questions. In the interest of time, we're going to skip narrowband imaging for today, but the sort of snippet of this is it sounds like the jury's not out. Some data offers that it can improve ability to detect PAS, and others are inconclusive. As we move to our peak and our pits, we have a video here of a pit of fees and where we had to make some inferencing. So here we have a thin liquid bolus, and you can see after the swallow, the endoscopist goes to look into the laryngeal airway, and we can see the trachea is largely clear, but keep your eyes fixed on the trachea for a second. We may see something. Now we have a lot more white in the trachea. So with fees in the whiteout period, we're left with inferencing. This patient went for further diagnostics and was found to have communication between the trachea and the esophagus, a tracheoesophageal fistula. And as we continue our mountaineering exploring of peaks and pits, I'll hand things back over to Laurie.
Okay, thank you. So that was super interesting. TEFs are always really hard to define, I feel like, even on fluoro sometimes. So if you can play the image, so this was a peak for fees, right? So this patient came to me and had a constellation of symptoms. I have trouble breathing when I'm walking. Things feel like they're sticking in my throat. And so you can actually see an anatomical variation on the right side of the larynx. You can see sort of like a prolapse. This is what I called it when I described it, a prolapsed arytenoid, right? And so this would not be appreciable on fluoro for sure. But if you can play the right side, please, you can see that with regards to swallowing function, liquids, this is liquid swallowing, and the patient actually swallows fairly well without any airway invasion. And so we sent this patient sort of expediently to ENT to ensure that, that was not tumor below or, something more sinister. But FEES allowed us to detect this when this patient was being sent to multiple different specialties for problems breathing and swallowing. This is another peak. This is another peak where, we have a seat at the lymphedema table, right, as speech language pathologists, where, PTs and OTs and massage therapists, this would be their, bread and butter. And now the internal edema that we're able to appreciate on FEES is something that really sets us apart and puts us at the forefront of swallowing management and lymphedema therapy in the head and neck population. And so that's a peak. And then our last pit is, you can see pretty clearly, if you play that left side, you can play them both simultaneously. So this was a patient with one lung. He had lung cancer and he had a pneumonectomy. And as you can see on the left side, nice image quality, decent. This is it's a disposable scope. But over time on that right side, if you play the right side image, you can see this was sort of at the end of the study. So one of the pits of FEES is really image degradation, right? Sometimes we just can't find our way, right? I mean, really, we can't find our image. And I mean, maybe it was endoscopist error. I've been doing this for a long time. I tried just about everything to clean off this scope, and it was really challenging. And so there could have been image degradation from the scope itself, from fog, from I'm not sure what, but I could not do it. Somebody else can do it. Please tell me how. All right, next slide. In conclusion, we know that FEES is a well-established tool in the literature, and it's not just if you can't perform fluoro. That's not what it is anymore, and we're grateful for that. In many cases, it can have greater sensitivity in detecting airway invasion and/or residue than fluoro. We need to understand things like scope type, other variables, cleaning, things like that when creating, FEES programs, and we need to be able to liaise with multiple departments and our colleagues from different departments. We need to understand competencies required by state institution and if there are any changes with our national organization. We know there are validated scales for safety, efficiency, edema, and there are the beginnings of some normative data, which may tell us that we might be over pathologizing things. And so we really need to consider that. And with any tool, we need to think about the peaks and the pits, what we can see, what we can't, what we need more of. And then the most important thing, which is one of Aaron's great contributions to our field, thank you, and Dr. Palmer as well, is that we need to look at the whole patient, and decision-making paradigms like the bolus framework help us utilize information derived by tools like FEES and fluoro to help our patients as whole people. And so I just wanted to say thank you, and we look forward to questions. I mean, thank you for your attention. And that's it.
And if anyone's interested in the handout for all of the publications that we talked about today, we have them organized by sort of area. Just scan the QR code and that'll take you to the document.
Wonderful. Thank you both so much for your time this evening. A quick couple of housekeeping items and then we'll dive into Q&A. If you missed it at the beginning, this course is eligible for ASHA CEUs. Just fill out the survey. I put it in a chat and it will also be sent out via Zoom, and it will be open until next Thursday, at which point we will submit for ASHA CEUs. And then if you want a certificate of completion, just send us an email at tims-univ@tims.com. We do have several questions, so we'll go ahead and dive in. Selena Reese asked, are you using the Patterson scale for populations outside of head and neck cancer?
Is that for me?
Yes.
Okay, you can use it for populations outside. So I would think, so when we do FEES, so I have a head and neck cancer population, but I also have an other dysphagic population. And there are some patients that, we have had a patient that had a long-term NG tube, but it was just a terrible situation. And he had, probably tons of reflux. And so his arytenoids had a lot of edema. And so it was really a way for me, it's not validated on other populations, but it was certainly useful for me to look at serial fees that we did, several weeks, between, and to take a look at that resolution of edema once that nasogastric tube was removed. So I think just like digest fees has not really been validated, or digest itself is just starting to be validated on other populations. I think if it's looking at a parameter that exists in other populations, for me, that is enough preliminary evidence to apply it. Would I use it in a research publication? Maybe not. I'd want a little bit more validation there.
Wonderful.
What do you think, Aaron?
Yeah, I agree completely. And I knew of the revised Patterson leading up to this presentation, but really learned a lot about it from Laurie. And I just love all of the parameters with it. And it's such a useful tool. And it's in your Tim's toolbox there of things that you can use, so forth, coming soon. And yeah, I think it's a useful tool, and I think it moves us away from the subjectivity of things and moves us into objectivity. It helps with fidelity. It just helps with the various aspects of reliability and so forth. So I think it's good.
One little key point in her publication, the actual photos, the color photos are in supplementary material. So you have to look in the paper. If you have the electronic version of it, you'll be like, where are all the photos, right? To compare, they're in there. They're just in that supplemental region.
Yeah, we use the revised Patterson at my hospital, and we have it printed out and hanging on our fees cart with the images. So
yeah, we have them.
Have
ours here.
Love that. I feel left out. I need a handout.
They're
I love
laminated. These are Jackie's. I have my own in my other office.
Along the lines of scales, one of the attendees said, how many scales are too many? How many do you use in your reports? And how do you structure your note so that it isn't overwhelming and providers can understand your findings?
that. You want to tag team this, Laurie? That's a great question.
Yeah, you go first. I'm going to think about that.
So that's a great question. I think some things to look at is what is the data behind this. So there's some data on using the measures from VASIS to determine a digest severity scale. So maybe we can use those two tools together. Laurie and I were having this conversation before the presentation of do we need to use things like digest and the Yale together? They both give us measures of efficiency. Maybe we just pick one. Of course, we want some sort of, what I would say is we want some sort of efficiency measure, a safety measure, an edema measure, and a secretion measure. I think something that can be helpful for, wherever you're at, depending on the type of physicians that you're working at with medicine, GI, ENT, pulmonary, whoever, is at the end of your note, you sort of just have a synopsis of everything, maybe a bit about anatomy, a bit about safety, a bit about efficiency, and then what are you doing to address all of these things of, aberrant safety, you're doing this, aberrant efficiency, you're doing this. And then a source in that area of maybe you're using the revised Patterson scale, maybe, we're doing referral to outpatient speech for some lymphatic therapy or PT, depending on how things are in your respective location. I think that was everything. That's everything that I have. Laurie, you have some thoughts?
Yeah, no, I think you answered that beautifully. And this is a great question. And we struggle a lot with this, right? Because we have, like, in our institution, we have protocols and we have research studies going on. And so how much is too much and how much is like just not feasible for you, right? No pun intended or pun intended. But so in our institutes, I think the bare bones is something like a digest fees where you're looking at a safety efficiency rating. If you can get, if you do not feel comfortable using the digest fees because it's not necessarily validated on a non-head and neck population, you can use something like the Yale and the PASS together, right? That will give you a safety and efficiency rating. And so basically those are the big functional impairments, right? If we need to say something about structure, just like in Susan Langmore's old paper, right? We need to say something about structure, those pre-swallow tasks. What is, is there, asymmetry? Is there good symmetry? What are any structural, considerations that we have here? And then, in ours, we do a lot, like we go back and forth and say, Well, if there's residue in the vallecula, right, most likely there's some issue with tongue-based retraction, right? And so we try to sort of pair the functional impairment with an inferred physiologic issue, right? Sometimes you know that from the disease process, sometimes you know that from the subsite of cancer. But I think as long as you're doing some of those things, you might not need all of those other scales, and there are just so many out there. So my other answer is pick which works for you, right? What do you like? I like Digest. Other people like Vazes, which is a wonderful tool. I'm just not trained on it. So I think that I think Digest is easy. It's quick. We use Digest as well on our fluoros. And it's just, for me, it's a lot. I love Bonnie Martin Harris's work, but the volume of patients that we see is it's just hard for us to get all the scales in. So understood 100%. I think it's different if it's a research paradigm. I think that you need to have, consistency of data points. But clinically, you do what you can, you do what you can do.
Wonderful. There's a question for Aaron. Adrian said, Aaron, you said normal whiteout was between 12 to 24 frames per second. And what was the other criteria you mentioned for normal whiteout?
Oh, so that publication measured whiteout using images that were recorded and stored at 30 frames per second. So that was the other parameter looking for those normative data. I'm not familiar with any other data assessing whiteout in a non-30 frames recorded and 30 frames stored publication. Good question.
This question is in regards to Laurie's discussion pertaining to image degradation over time with fees. Lillian asked, how often does that occur? Occasionally, frequently, or rarely?
I mean, I think it happens to me at least once a study where I really lose view. With degradation that bad, I had to attribute it to a disposable scope potentially. And sometimes you do get a bad batch of disposable scopes. That happens, just like you might get a bad batch of strawberries, right? You get a bad batch of disposable scopes and they don't work well, right? They're not picking up images. I mean, how frequently? Usually once in a study, I will lose image, right? And so I just try to back up the scope and advance the scope. I mean, this particular one sort of made me angry because this guy had one lung, right? And so this was a patient that had been eating, had been drinking. His oncology team said that his chest CT looked worse. They made him completely NPO. And here I am trying to make decisions based upon, a poor image. And so that was just a little challenge there. I would say it happens, but I feel like most skilled endoscopists can get their way out of it. For whatever reason, this just persisted. And it was almost like the light went out. That's what I felt like. So to this degree, doesn't happen to me very frequently. And I think that would probably be your experience too, Aaron. I don't know, I'm speaking for you.
No, I would agree. I would agree. Sometimes, it's mucus, you get splashed with the bolus, you get jelly, someone coughs and gets something on the scope. And like Laurie mentioned, with time, I think it does get easier to navigate your way throughout that. When you're initially starting, you may have that happen a little more frequently as you find your way there.
There are also some tricks like ENTs. You'll see them take the scope, have the patient open the mouth, tap the tongue because they say saliva is a natural defogger. There are defogging agents if you're finding your scope's getting really foggy, especially patients that are on high flow, things like that you have sort of this humidified area where your scope is sort of hanging over. And so, I mean, if it's happening consistently, you might want to think to yourself, like to that degree, like what's going on here? Is it the scope? Is it the me? Is it that I'm not pulling my scope back a little bit during the bolus, which, most courses will teach you to do, right? So you sort of stay out of the way of the bolus and then advance your scope after the swallow. So I think for me, that one particularly made me scratch my head because I think it was something with the equipment, not frequent.
Wonderful. We will take probably just one or two more questions just since we are over time and I want to be respectful of everyone's time this evening. But this attendee asked, when describing what you see on fees, how are you, basically they're asking, how are you documenting in a way that doesn't go out of our scope of practice and avoiding using terms that would be more appropriate for an ENT to utilize?
That's a great question. I think just describing things can be helpful. Describing color, symmetry, location. I think those are big things that can be helpful as clinicians navigate. How do I document things with staying in my scope of practice and not overstepping? What do you have any thoughts, Laurie?
Yeah, so I think I like that. You describe whatever anatomical pathology you see. We'll often call something a lesion. We're not calling it a cancer. We're saying there's some sort of a lesionary like, something on the right vocal fold, of the posterior aspect. You can describe the arytenoid sort of falling over the airway, right? And that would, we can use words like prolapse because that's not a medical term. That's really more of a descriptive term, right? So, I stay away from things like, ooh, that's a squame or, squamous cell carcinoma. Like I'm not using those types of terms. We'll use things like erythema, right, to describe things that are red, right? So I think, to Aaron's point, descriptors are really our friends, talking about laterality, talking about position within the laryngeal vestibule or in the pharynx, just where it is, even like an 11 o'clock, when looking at this. And sometimes what I'll even do if there's something really interesting, like in this fees report, I screenshot it and I dropped it right into the report. So nobody even needed to go to my images. They needed just to look at that image and say, oh, that's what she's describing. Okay, this warrants some further investigation. And you can always really sort of qualify it with requires clinical correlation by MD. I think if you put that there, you're saying, I am not the diagnostician for anatomical issues. I am just describing this and saying, I am now sending to you, to a medical professional for a valid anatomical diagnosis.
I love the idea of the screenshot.
Do that all the time. Do that all, even with my fluoros, I take screenshots of like osteophytes. I'll throw them like, things that are funky just because it's easier for everybody than to call attention to the images. Although we want everybody to look at our images, we know that, in our busy lives, that's not always feasible. Again, feasible.
You at it again, Laurie.
I'm at it again.
Well, amazing presentation, and thank you both so much for sharing your expertise in the Q&A. We did have a couple of questions regarding the handout. So just so everyone knows, the handout will be uploaded to our website with the replay of this event. So you'll actually just be able to go to our website tomorrow, check out this replay, and download the handout if you were viewing on iPhone and couldn't scan the QR code. And then again, if you missed it, just complete the survey for ASHA CEUs by next Thursday. And if you'd like a certificate of completion, just send us an email at tims-univ@tims.com. With that, we'll go ahead and close out for this evening. Thank you both so much for your time and expertise, and thank you all for joining us.
Thank you, Brooke, and everyone.
Thank you. Have a good night.
Laurie, well done. You did so well.
You did so great. Oh my goodness. We're going to go